All right. Welcome everyone to this special CME talk. And this is a collaboration between ANACP and CAGA. And here is thanks to all the GI specialists giving us their expertise. So first, let me introduce myself. My name is Tao Wang. I'm an internist at practice in Washington State. I'm a representative of ANACP. So let me quickly introduce ANACP, and then I will hand over all the stage to our GI colleagues. So for ANACP, we are established in 2016. And it has been about 10 years, and we are still growing. And I just talked to our GI colleagues, and with ANACP, it's American Chinese physician. We are a big group of physicians and from different specialties, including PCPs, including GI specialists, oncologists, and pathologists, and all that. But our goal is to be together, to be stronger together, and to learn from each other, and also networking more. So before we do the CME talk, we always have to do a disclosure. So this is a accreditation requirement. So we are here just to make sure we don't have anything to disclose, and our speakers will mention about that as well. And for CME claim, we have to go through a lot of process. So first we need to register the webinar, and after the meeting, you will receive an email with a link. We can claim the CME credit. All right. And the last thing I want to do a little bit advertisement is about our annual conference. It will be held in July, from July 10th to 12th. And if you need more information, go to our website, and it will be a big event, and a lot of people will enjoy that. So now I will just hand over this stage to our GI colleagues. All right. I will stop sharing. And Dr. Song, now it's your turn.
Thank you, Dr. Wang. Hi, everyone. My name is Gloria Song. Well, my Chinese first name is Yilin. I'm currently working as the secretary of CAGA, stands for Chinese American Gastroenterology Association. I'm myself is a second-year internal medicine resident here at University of Maryland Midtown campus. I'm about to apply for fellowship this year. So CAGA was founded 2 years ago in 2024 during the DDW, which is stand for Digestive Disease Week. And then we're about to have our second annual conference, which is very exciting. And then currently we're selecting outstanding abstracts, so then we can promote more opportunities for Chinese American gastroenterology or internal medicine residents to present their works. And then the goal of this foundation, very similar to ANACP, is also to create communication and the partnership, and also create the benefit as trainees. I didn't prepare any slides, so I'm gonna put our website in the chat. So if anyone is interested to join us or interested to find out more information about our second annual conference, it's all in the website. Thank you. And now I'm gonna hand over to introducing of Dr. Kong.
Hi, I'm Dr. Cindy Chu, and I'm practice at Albany, New York. And then, so let me briefly introduce our speaker, is Dr. Xiaofei Kong. So Dr. Kong is a gastroenterology and physician scientist at UT Southwestern. Can you hear me?
Yes, we can.
Okay. And his practice focuses on patients with celiac disease, inflammatory bowel disease, and then complex and autoimmune disorders, and including CVID is a common variable immunodeficiency, and other primary immunodeficiencies. He completed early medical training in China and served as a resident at Ruijin Hospital, Shanghai Jiaodong University School of Medicine. He earned his Ph.D. in immunology at Paris in France and spent several years as a clinical scholarship at the Rockefeller University. He then completed his GI fellowship at Columbia University before joining the faculty at the UT Southwestern. And so he published dozens of the papers now. And without further delay, let's welcome Dr. Kong.
Thank you, Dr. Zhu, for your kind introduction. And also, I would like thanks to Dr. Song, representing CAGA, as well as Dr. Wang representing NSCP. I really appreciate you invite, and it's really my honor to be here to share some our research and understanding about celiac disease. So, okay, can you all hear me well? Okay, good. Yeah, I have nothing to disclose regarding financial relationship with any ineligible companies. So let's first talk about a patient, as we all practicing medicine in US. This is Miss X, as a 61-year-old white female, and she presented to primary care physician to establish care, and she had a history of GERD and some degenerative joint disease, menopause syndrome, osteopenia. She complains about left hip pain, especially prolonged sitting. She has been on physical therapy. She takes calcium, some vitamin supplement. Her social history was unremarkable, and her physical exam was unremarkable. And she got a bone density scan, and which was fine. She has osteoporosis in her left femoral neck, some osteopenia. She was diagnosed with age-related osteoporosis. So then she was referred to see endocrinologist before his osteoporosis, and endocrinology basically increased her daily calcium as well as vitamin D supplement. So she now is taking about 1,200 milligrams of calcium per day. When she follow up after 6 months, she didn't get better. So she discussed with the endocrine, and she's unwilling to take any oral alendronate. So she was started on reclast infusion to help for her osteoporosis. But still, after 1 year of the treatment, there's no significant improvement. So the endocrinologist ordered a urine test. This is 24-hour urine calcium test. A normal level is around 100 to 250 milligrams, but for this patient, her calcium level had been consistently low at 71 milligrams. So she was diagnosed with hypocalciuria. What could be the cause of hypocalciuria? We are talking about celiac disease. So there are a couple of reasons. It could be vitamin D deficiency, but her D level was totally normal. The other differential including malabsorption and kidney issue. Well, we think about what's the main cause of malabsorption in the United States. The most common is celiac disease. And so she was tested, and she was found to have very high tissue transglutaminase IgA level. It's above 100. So from this case, we can see how the disease can present. So the clinical presentation of celiac disease varies a lot. typical patient or classical gastrointestinal symptoms, including diarrhea, abdominal pain, weight loss, bloating, and constipation. However, a significant amount of patients that do not have any GI symptoms. They could have extra intestinal symptoms, including arthritis, dermatitis, hepatiformis. As I mentioned, like this patient, the presentation was osteoporosis. They can have the dental problem. Abnormal LFT or transaminase can be the only symptom or abnormal findings when they're presented to the clinic. Some patients have neurologic presentation, including ataxia, epilepsy, or neuropathy. And psychiatric problems, including depression or ADHD, have been reported. The subclinical disease, how they the physicians thought about celiac disease, including they might have iron deficiency anemia, vitamin D deficiency or vitamin K, short stature or idiopathic, especially in pediatric case. Some of the children were diagnosed because they have delayed ingrowth. Right? They're probably in the 10th percentile in terms of their height or weight. Another scenario, it could be infertility. So, as I said, this is a disease can have many different phases. So, what in kind of categories we can classify celiac disease? There's a couple of categories in our in gastroenterology. When we saw this patient, we put them either classic celiac disease, those presented with villus atrophy, malabsorption. They have symptoms as well as histology responding to gluten-free diet. And the others can be totally asymptomatic. They will find from screening or evaluation for an associated problem. Those who have type 1 diabetes, autoimmune thyroid disease, or osteoporosis, they have increased risk of celiac disease. The third scenario is family history, which is one of the strong predictor. 10% of individuals who have a positive family history, they have the chance to be diagnosed with celiac disease. So familial clustering is very common for this disease. The third group is called atypical celiac disease, which I mentioned earlier. The fourth we call potential celiac disease. Those are the patients with the positive serology, but the biopsy from the small intestine was normal. The hallmark of the intestinal lesion of celiac disease are following. So you can see on the left side, as this is normal. Can you, okay, let me put my laser on. Okay, can you see my arrow laser?
Yes, we can.
Okay, good. So this is normal duodenum. Here we can see this villus crypt. Those with celiac disease, the three key features are they have increased intraepithelial lymphocytes, which we call IEL. And the second feature is called cryptor hyperplasia. Those are below, which the development center of the small intestine. The third feature is villus atrophy. And based on these three features, we have a MASH classification based on called MASH 1, 2, 3. Those with MASH 1 or 2, the main presentation are increased intraepithelial lymphocytes from the biopsy. For MASH 3, A, B, C, the features are they have different levels of villus atrophy, either mild or partial, subtotal, or the total villus atrophy. And currently, because of like different clinical trials, one sort of more subjective way of measurement called VH, villus height to crypt depth ratio. You can see from the left side, you can measure the villus height and the crypt depth. So this ratio can evaluate how much villus damage the patient have. So these are important sort of histological features we are looking for when we monitor those with celiac disease. So this is a busy slide. This is published by a recent ACG guideline about diagnosis and management of the celiac disease, which I will focus on today. So you can say if we have a clinical suspicion, if patient on the normal diet, we will test for the tissue transglutaminase IgA and the total IgA. There's a couple of other names here, so I want to first explain why we test that, why those are important for celiac disease. So first, let's talk about what is TTG IgA. Why I mentioned the earlier patient with osteoporosis with so high TTG IgA level. So TTG IgA tissue transglutaminase it's an antigen, but the earlier version of this test is called EMA test or endomysium antibody. So what the test about, as you can see on the middle, these are the representative structure of monkey esophagus section. You can see this endomysium sort of cover different muscles. And the earliest finding was from about 40 years ago. And the scientists basically find individuals with celiac disease, they can have an antibody binding to this endomysial structure, which presented on the right side. That's our reticulin-like pattern. And after many years of study, 14 years later, another group, this main work was done by Dr. Chopin. He identified this binding to the endomysium is actually its antigen is tissue transglutaminase. This is the early study identifying its antigen. So nowadays, these two tests have been widely used in the screening, particularly the TTG-IgA, which different labs developed sort of indirect ELISA to measure the antibody binding to the tissue transglutaminase. And the EMA or endomysium antibody is called immunofluorescence. I will not go details for basics. It's different test could be served as a complementary when someone have a positive TTG IgA test. So what's the epidemiology? How prevalent is the celiac disease? Based on the serology test, the TTG IgA screening. So this is a widely cited paper in the field. This is a meta-analysis of 96 articles to see how common of those with positive serology. You can see here from Europe or Asia, seems all have above 1% of the positive rate. However, if we look at those have positive serology to see how about villus atrophy or the tissue damage, the biopsy-proven celiac prevalence rate was lower. It's about 0.7%. One of the issue, even this paper was widely cited. One of the issue when we sent the serology test, let's say TTG IgA to two different lab, let's say LabCorp or Quest or Mayo Clinic, they different lab have different tests. It's not standardized, there's possibility of false positive. And actually, there's also inconsistent findings compared to this meta-analysis. This is a paper published to analyze the enhanced study to see how the prevalence of those with positive serology. So this study evaluated more than 14,000 participants who have checked for these two antibodies, either TTG-IgA or the EMA. They find overall positive rate is about 0.79% in US, and it's highest in those with white, more than about 1%. But for those with reported as Mexican or African American or Black, the positive rate is much lower. It's only 0.23% or 0.2%. So this suggests celiac disease could have different prevalence among different racial or ethnic different group. So our group actually started to see what's going on with our cohort called, this is a cohort called All of Us. So All of Us is a research program that's initiated by NIH. So All of Us program, they collaborate with different medical center or health providers. So those who interested participate into this research program, they will have the electronic health record sort of centralized to the All of Us research program. In the meantime, those who are interested to participate in this research program, they are asked to answer a survey. And this survey asks questions about more than 800 different questions. Then all the center labs sort of, they're putting all those information together while interested individuals, including students or residents with faculties, we can look in on this data and analyze and to see whether we can find something unusual. One particular sort of points from all of us, or the strengths of this research program, is about diversity. They want to enroll as diverse as possible. So based on these two different resources, including EHR or self-reported, we've identified a total of 3,000 have celiac disease. And another unique advantage of this program, they have all the genomic data. And so this patient get tested for their genetic factors. We also have their laboratory values. So what all of us lead us to know is, again, we find celiac disease is more common in female. The prevalence is about 0.9% compared to male as 0.3%. When we look at different racial or ethnicity group, you can see this with white have the highest, and followed by Hispanic, and this with Black or Asian have lower prevalence. So you might be questioning, since this is a huge program with enrolling almost 500,000 of the participants, and we relied on the EHR, the diagnostic code, and self-reported information. Could those be true? Could this participant, what I mentioned here, the 3,000, are they true with celiac disease? So we can look back on this guideline to understand, if we have a clinical suspicion. Unfortunately, among those patients, 3,000 patients, not all of them we have their serology number, but majority we have their genetic data. You look at celiac disease, if someone has clinical suspicion already on gluten-free diet, then we can using HLA testing, whether patient are DQ2 or DQ8, whether they're positive or negative, to determine the next path. So the question was whether those some of them may not have even have true celiac disease. They might have negative DQ2, DQ8. So to further understanding whether they have DQ2, DQ8, we're going to go a little bit deeper, okay, about what means DQ2 or DQ8. DQ2 or DQ8, those are serotype. This is a massage or classification identified 40, 50 years ago or even longer. Well, in that time, there's not much genetic sequencing data available. People using antibodies to say which type of the DQ individual might have. And in current days, the DQ2 or DQ8, we know it's more clearly about that they actually can have different genotypes. I will not go into more details. The most common is called DQ2.5, and the second one called D2.2. Some of the gastroenterologists call it half DQ2, and the DQ8 was one of the other risk genetic factors for celiac disease. And those risks are different. Different HLA-DQ have different risks for the individual for developing celiac disease. We understand this is also very basic slides. When we send to Europe for different genotyping, these are a couple of the DQA1 or DQB1 tested. But the only thing you need to remember, sort of know, is that DQ2.5 is the highest. And in European study, it presented in 85% of individuals with celiac disease. So come back to the all of us cohort. Well, before we come back to the all of us cohort, why those DQ2.5 is important? Now, this is a study called TEDdy study. This is a study from sort of collecting enroll patients from different countries in the world. And they did a genotyping of HLA and follow up those patients over a certain period of time to see how the genetic risk contribute to their future diagnosis of celiac disease. And this study was first designed for identifying the risk for type 1 diabetes. As a second sort of outcome, they included celiac disease to see how those with different risks, how they present. And one key is those have the homozygous DQ2.5. These are the line here. Those are the individuals have the highest risk. By the age of 8, 26% of them have the diagnosis of the celiac disease. So when we look at the all of us cohort, as I mentioned, as we find patients based on their EHR or self-reporting, you can see there's about 17% of them that do not have a DQ2 or DQ8 risk haplotype. Although the DQ2.5 frequency is much higher than non-celiac controls, but compared to have positive serology, the rate is way higher. So this suggests even patients they're reporting, we are documenting them have in their EHR have celiac disease. They may not have true celiac disease. So we sort of get stuck there and try to figure out why. Why so many people, 70% is not a small number, do not have a risk allele. So first we did was when we analyze their risk, we sort of need to remove those do not have DQ2 or DQ8. Then we look at the distribution of the different the genotype to see which one have the stronger risk. we can classify them on high, moderate, or low based on the difference between those with celiac disease and those with non-celiac disease. And you can see in different combination have different risks. It's not unifying. And those have homozygous are so far the strongest risk. Then to tell those why those have no, low risk HLA, DQ risk. So we need to find a model. So help us to predicting who have true celiac or who do not have true celiac. Now we have a lot of data, a lot of the diagnostic code, lab values, and genetic data. Can we using machine learning to find a predictive model to help us to differentiate those who have true celiac who do not have true celiac? And to do that, we need to have the gold standard that which we used those who have seropositive celiac disease. We tried different ways. I will not go details how the different model. One is called polygenic risk score, which we basically combine different genetic risk to see how it performance. And this have pretty good prediction, and with what we call area under the curve is 0.86%. So the accuracy about 86%. It's not bad. Then we try to look at can we improve. So we started to looking at hundreds of different factors and using machine learning models to improve the prediction. And we find based on HLA, family history, and symptoms, some or other diagnoses, including diarrhea, vitamin D deficiency, anemia, or hypothyroidism, it have similar performance in predicting those have seropositive serology. Furthermore, we sort of improve this prediction, sort of combine polygenic risk score and family history or different clinical symptoms, and we can achieve the better prediction accuracy. So when we got these predictive models and we want to test how accurate they are in predicting those with celiac disease from different genetic ancestry. You can see based on this score, we call it over-CD score. You can see it can differentiate the difference between those seropositive or controls is very significant. 90% who have seropositive celiac disease and have the score above 4.17. When we look at the entire cohort to differentiate individuals from different genetic ancestry, you can see those with European have the highest, followed by admixed American. Majority of participants with admixed American ancestry are Hispanic population. And those with African ancestry, even we see the difference, but the significance as lower compared to those with European ancestry. So this is sort of a score we can use to understanding better the cohort and help us to discriminate who might have higher chance of celiac disease and who have low chance of celiac disease. When we look at the genetic risk, we find those have low genetic risk. Their overall frequency of positive family history are lower. However, their diagnosis, including migraine or asthma, chronic sinus infection, as well as you can see like irritable bowel syndrome, is much higher who have the low risk. So that suggests there's misdiagnosis, mislabeling in either EHR or patient reported. This is the common causes of this misdiagnosis. when we look at earlier studies, there's different reasons. Some are related to duodenum biopsy. Biopsy was not performed, and some patients may have a mild duodenum lesions. For instance, as I mentioned earlier, increased intraepithelial lymphocytes was one of sort of observation for the MASH score. But there's many reasons can causing the increased intraepithelial lymphocytes. And some of the patients even have this mild change. They had tested negative for serology, but still was labeled as celiac disease. Other case, serology was not even performed, or the patient have no response, no clinical response to a gluten-free diet. And this is a recent study, not recent anymore, but this is a study from a tertiary celiac disease referring center. You can see this center evaluate 198 patients. Some patients are the first diagnosis, they're called naive patient. A second group, they're called patient with a previous diagnosis of celiac disease. They might already on gluten-free diet. So among this group, 52 was confirmed, and half of them was questionable. So that requires further testing, either serology testing, biopsy, HLA typing. And what they find in this sort of previously diagnosed celiac disease, 43 patients have other diagnoses. And the most common other diagnoses are non-celiac gluten sensitivity, IBS, or functional dyspepsia. So, well, what are we going to do with this situation? We need to really understanding the disease pathogenesis and requires evidence to help the patient to have confirmatory diagnosis. And once the patient have diagnosed with celiac disease, they can get treatment. The key treatment is gluten-free diet. And these are the certain food, especially wheat, rye, barley, the most common food to contains gluten. Usually, this is a long list of food. Usually, I ask patient to go to the Celiac Disease Foundation website to get more information. In the meantime, it is really important to refer the patient to see the dietitian. For the case of time, I would be quick about, we need to be careful about different alcoholic beverage. Some of them contains gluten, including beers or soybean sauce. And we need to educate our patients about their food and those choices. The dietitian referral it's the importance since we know the gluten-free diet can treat the patient. So 1 hour detailed education about gluten-free diet and dietary recommendation, a list of manufacturers of gluten-free foods should be discussed with patients. I usually talk to my patients about local stores. I ask them where you can find and how to look for the labels. As I mentioned earlier, a list of free food additives and ingredients. And 2 months reminder, either by email or phone, can help with the compliance. And when the patient come to follow up, we ask with different tools we can use. Some are related to the quality of life. Second, related to the adherence or the symptoms index. Energy level is really important. A lot of them were complaining about their fatigue. Actually, those sort of the questions I like to ask my patient, how about follow a gluten-free diet outside my home? Or what will presented to you when you have accidental gluten exposure? And some patients told me, they don't have symptoms before they got diagnosed, but when they started on gluten-free diet, they became more sensitive. They started to, when they have accidental exposure, they have more severe abdominal pain, vomiting, and diarrhea. And this is one of the study we recently published by one wonderful medical student, Bettina Anil, using all of us. What you can see here, for those with celiac disease, they're more likely to report moderate, severe, or very severe fatigue. And in the meantime, a lot of patients don't have great interactions with health providers. You can see on the right side, about 10% saying providers doesn't listen or the provider acts as they are better than the patient. They also have the feeling, thinks doctors thinks the patient themselves are not smart. So this of negative feelings also become challenge to providing care for such patients. How about other tests when the patient come up for follow-up? One thing we want to know is that those have small intestine healing. This is a study from Mayo Clinic where they find if it is 2-year gluten-free diet, about 1/3 patient recovered, 5 years, 2/3 patient. And we want to know whether the patient follow well the gluten-free diet. One measurement would be using the serology. How about their TTG-IgA level? And we look at anemia profile and their malabsorption, whether vitamin D, zinc, other electrolytes will be whether it's abnormal or not. And we need to follow about their bone density scan and be asking about their vaccinations. So this is another study we conducted and published by Dr. Changlin Geng, and he's a resident in New York. What Changlin find when the patients start on gluten-free diet, their TTG-IgA level dropped rapidly, but almost take 5 years to plateau. And on the right side, as you can see the similar pattern during the initial diagnosis, TTG-IgA was high, follow-up much lower. So can TTG-IgA be helpful, or how helpful it is for celiac disease follow-up? One feature we call persistent villus atrophy. Those are patients already on gluten-free diet, but they still have small intestine injury. And unfortunately, TTG-IgA cannot detect that. So that means even TTG-IgA get lower, but still they have the tissue, they still have the tissue damage. This is the problem. So we are still looking for future markers that can tell us who can have this persistent villus atrophy. And this is a recent study from UK. Basically, they looked at this group patients with persistent villus atrophy, and they find those patients have more likely to develop refractory celiac disease, ulcerative gastreitis and ileitis, abdominal lymphoma, and small bowel carcinoma. So we have when someone who have celiac disease, we really need to think about not only about gluten-free diet, but also need to think about how their tissue healing. And currently, we don't have enough evidence to say how often we should do endoscopy. As I mentioned earlier, the 5 years recovery rate is about 66%. And this study also mentioned some of the key predictive factors, including age of diagnosis, their clinical response to gluten-free diet, and their adherence to the gluten-free diet. I will be fast on this part about some of rare scenarios, including refractory celiac disease. Those are individuals who are not responding to a gluten-free diet. They have clonal T cells in their small intestine. And unfortunately, the mortality rate remains high for this group of patients. So, in addition to the gluten-free diet, some other medications we can try in the clinic when patient not responding, including budesonide, vedolizumab, or JAK inhibitors. But we currently do not have enough data to say which one is better. With hopefully we're gonna have in the future we may have other choices. Like this is a recent clinical research clinical trial. It's phase 2. It's called TAC-101. So what this study is basically they conjugated gluten into nanoparticles and doing IV infusion. So this nanoparticles went into either liver or the spleen, and those other area can induce tolerogenic in the macroenvironment. Basically, those T cells responding, making response for the gluten antigen, they can sort of become more tolerant. They can get removed or energy and to sort of prevent more tissue damage. And I will be brief in the sake of the time. You can see the study participants are actually well-controlled celiac disease. So they ask them, well, can we give you gluten challenge? Before we challenge you, we're going to provide you 2 doses of TAC-101. Then by the day 29, they will do the duodenum biopsy and to check whether the challenge caused tissue damage and how the TAC-101 can prevent those tissue damage. And in short, you can see this 13 patients received TAC-101 before gluten challenge. Their tissue damage, there's the sort of this value called villus height and crypt depth. It's comparable. There's more not significant tissue damage presented in those received TAC-101, but for those received placebo, you can see significant tissue damage after 1 month of the gluten challenge. Another study was published in New England Journal of Medicine. This study basically studying the inhibitors of transglutaminase. It's called Z1227. And the research design was pretty similar. They also want to see how it can prevent tissue damage. And the key results are from this figure. And you can see those received placebo, they have clear changing or the villus height got shortened. But those received the Z1227 and they can sort of have maintained the same similar villus structure. So it's 7:50, and we went through many topics. We discussed about the clinical presentations of the celiac disease. As I mentioned, not all of them have GI symptoms. It can be pretty heterogeneous. I also discussed about the serologic and histologic criteria for the diagnosis of the celiac disease, how the TTG, IgA, and the EMA was performed. We discussed about epidemiology of celiac disease across different racial and ethnic group. I didn't have time to mention about how celiac disease in Chinese or Eastern Asian. We actually require some more data, more studies to understand So far, I don't think it's as prevalent as those in European. It's more like, we need more data. I mentioned about genetic risks and talked about the common reason of the misdiagnosis. We are practicing medicine in your society. A lot of people believe gluten-free diet is good. Um, but despite we don't have sufficient evidence to say they have true celiac disease. I mentioned about how to monitor those patients on gluten-free diet and briefly talked about those investigative therapies for the future celiac disease. Thank you for your attention. I would like to thanks to all of us research program, which makes us possible to investigate large number of patients and participants with celiac disease. I would like to thank to many of they are medical students, resident, or even pre-meds. They joined me, helped me to study celiac disease. I mentioned some of the results from Bettina Anil and Changlin Gong, but many of them have, all of them listed here have been contributed to my research program. And I would thanks to my colleagues, this our celiac disease program, including pediatric gastroenterologist, me, dietitian, social worker, and patient advocacy group. And of course, I thank for my funding agent. Now I'm open for questions. Thank you.
Hi, Dr. Kong. As a panelist, I would like to thank you. You're a true expert, a world expert. You probably see more celiac disease than any one of us combined with your all of us study and your basic and clinical research program there. I just wanted to make a few editorial comments about how much the celiac disease research has come. This used to be believed a Irish disease. The Irish population has the highest clinical diagnosis for many, many decades, and most of them were diagnosed as a pediatrician. If you look at the European pediatric diagnostic guidelines in the 60s, it requires 3 biopsies to diagnose the disease. The baseline, the withdrawal of gluten-free diet, and the re-challenge. So 3 diagnoses. And then the serology came, endomysitis antibody came, but endomysitis antibody requires immunohistochemistry, very labor-intense lab study. It requires to use either monkey esophagus as the substrate or human umbilical cord, smooth muscle tissue as the substrate. And then in the 90s, late 90s, the German lab, as Dr. Kong presented, discovered tissue transglutaminase antibody. How did they discover it? They used the celiac disease patient IgA antiserum to put onto the substrate. And they identified the precipitated out of the smooth muscle cell line at 85 kilodalton protein. That turned out to be tissue transglutaminase. Not only tissue transglutaminase was important for diagnosis and made it easy to screen subclinical patients, it is also pathophysiologically important because tissue transglutaminase deamidates gliadin. And only after deamidation of gliadin, the gluten becomes toxic and induces inflammation. So it's fascinating to see how celiac disease research has progressed. And I have 2 or 3 questions for Dr. Kong to comment on. One is your report about tissue transglutaminase antibody IgA is not correlating to persistent venous atrophy. I wonder if it correlates to intraepithelial lymphocytosis, if not to the atrophy. If the antibody is elevated, do you typically see persistent inflammation there? I would imagine so.
Well, the short answer is as I mentioned, TTG IgA, the lab value drops very fast on gluten-free diet. It drops 90% after 1 year on gluten-free diet. And for IEL, as I mentioned also, Uh, it can many there's many different etiology. If someone have H. pylori, they can also have increased IEL. So we don't know whether how we actually had the earlier data. Okay, I didn't show it. Charlie saw there's no good correlation between IEL inflammation. Right? It's mainly and another thing I didn't have time to talk about. When we saw those TTG IgA values, they are above 100, above 200, but that means they really have a lot of antibody. And current clinical diagnostic lab dilute serum 1 to 100. And there could be a lot of false positive, at intermediate. It's not really diluted enough. But in Europe, they have different approach. As I mentioned, different labs are measuring differently. Some labs will do more. And if some, I didn't mention Peter Green is one of my mentor and collaborator. He sent the same patient for two different lab and comes up with different values. So there's a lot of interesting part regarding
A lot of there. So my second question has to do with some home kits for
yes.
gluten testing. I wonder if you use that for your patient population.
That's a great question. There's currently this kit available. In some of the pediatric cases, family, especially the stool test, they want to know whether the kids still have gluten or not. Um, yeah, some of my friends they provide those kits to the family members, but so far I'm mainly taking care of adult. So I haven't really give anyone this testing kit about the stool testing. Yeah.
Okay, we'll open for general questions, and Dr. Gloria Song will go through the Q&A questions and pull from the audience.
Thank you, Dr. Wu. Thank you very much for the wonderful presentation, Dr. Cole. I think the first question is from an anonymous attendee about what do you mean true versus not true celiac disease? Are they clinical different?
Well, the true celiac disease, we have to have serology, right? They have positive serology. They have to have tissue damage, right? The villus atrophy. They have to have compatible HLA. But some of them, they are not true that some are what we call non-celiac gluten intolerance. So they might feel, they say, I feel brain fog, and I feel tired once I get challenged. I'm intolerant to gluten. Those are sort of what I mentioned, meaning about seropositive celiac and not seropositive.
Thank you. And then I think the next question is from Dr. Wang. I'm not sure if Dr. Wang wants to. She put two questions in the chat. Would you like to
Yeah,
start
so
question
Dr.
yourself?
Wang mentioned about for a patient
Yeah,
with
yeah.
osteoporosis with
Mm-hmm.
GI symptoms when considered celiac disease workup. And I think for those, especially if you work in the United States, and I think those should consider workup. The test is total IgA and TTG IgA as a screening. Um, yeah, that's that's a clinical related. Currently there's no U.S. those PSTF preventation, so preventative task force force task. So they're not recommending to screening for celiac disease, but for those one who have a disease or indication for testing, we should test them.
And then I think her second question is about as PCP, should I recommend gluten-free diet for patient, use it as a treatment and or diagnosis tool?
Not as diagnosis tool. Now, if someone you confirmed, you should refer to GI, and so those can get evaluated. And I don't think you should try as a diagnostic tool. That's gluten-free diet, um, if they have true celiac disease, we would like to know their serology. As I mentioned, we help patients on regular diet when they come to GI.
Thank you. And the next question is from Dr. Zhigang Song. He actually also a Kaga member. His question is for patient with no symptoms and no lab abnormality, how often would you do EGD to detect MASH lesion?
Yeah, that's a great question. We don't have evidence to say how often we need to do. The guideline says 3 to 5 years. So my gut feeling is 5 years, every 5 years.
Thank you. And then the next question from Dr. William Liu. If you have time, can you talk a little about the current understanding of potential celiac disease?
Yeah, that's also another topic we don't. So there's different. So we have sort of this study from Europe about those potential celiac disease, and some of they follow them when they have serology. They follow them a couple of 6 months, 1 year, and a proportion of them become true, have villus atrophy, become true celiac, but some of them stayed the same stage. And for those patients, I think we don't have enough data, but gluten-free diet should be considered. If especially the serology level, the antibody level is high.
Okay, thank you. Next question is from Dr. Shen. Can bowel surgery trigger celiac disease?
That's I don't know. That's it could be for IBD. We saw some of cases after surgery they have IBD, but for celiac disease, I have really not really seen such situation.
Thank you. And we have two more questions from Q&A. The first question from Dr. Xi. He has seen some patient diagnosed with celiac disease and EOE from initial EGD, also with abnormal. Interestingly, after patient taking meds for EOE, duodenal biopsy get normalized. Do you feel those patients may not have celiac disease from the beginning?
Yeah, it depends on how celiac disease was initially diagnosed. And also budesonide, so if the patient treated with EOE with budesonide, and budesonide can help with the celiac disease. Some of, especially in the pediatric population, the EOE and celiac combination is quite interesting. Yeah.
Okay, thank you. Next question is from Dr. He. For counting IEL based on H&E or CD3 IHC staining. And his second question is when to order re-biopsy for follow-up.
Majority labs is based on H&E. Certain labs, especially for those with refractory, we do more sort of staining. Re-biopsy follow-up, as I already answered this question.
Okay. Yeah. Okay. When to order re-biopsy. Okay. And then there's a question from Dr. Wan, who is also a steering committee member of us. There are some case series and case reports on cancer immunotherapy inducing celiac disease. Do you have any comments on this?
Yeah. So this is great area. So, we saw those patients, as well as some patients with CAR T therapy or immunotherapy. They have villus atrophy. Their pathological feature is the same as celiac disease. They may even have more area with villus atrophy, not only duodenum, but ileum or jejunum. We get a better understanding how the pathogenesis. This may not be triggered by gluten. For CAR T, especially for CAR T therapy, we actually have a couple of such cases. It's really interesting. We don't know how to treat. This is a problem. Yeah.
Thank you. And then I think the last question is from another audience. Any characteristics imaging feature?
Um, Not really. MRE maybe no. No, imaging is not typical for celiac disease. And Dr. Wang mentioned about whether they have positive, do they have positive? Most of them do not have positive serology. And even we sent a lot out for the anti-entericides or autoimmune enteropathy. And so far, I haven't really seen much or any have sort of positive results.
Thank you. I think that wrap up all the questions we have so
I have
far.
a few questions.
Sure.
Hey, Dr. Khan, you had a wonderful talk, and you're a true physician scientist and then doing translational research. I have a couple of questions, and then so in your in the larger cohort study, and then serology is 1.4% versus biopsy 0.7%, it's like 50%.
Mhm.
Do you think it is due to a biopsy, the error, or just because the celiac disease actually affecting, like a Crohn disease, affecting segmental? So in my clinical practice, and I do see some extraintestinal modifications. So like some patient come in with a pancreatic insufficiency, and then I test the celiac disease is a higher, the anti-TDG IgA. And then another case is like autoimmune atrophic and gastropathy. And so the only thing come out, and it is anti-DDG is very high. They don't have any GI symptom. I mean, the gut symptom wise. And then the other patient actually I'm dealing with, and then he was undiagnosed and for years, and then he's like 42 years now, and then you find out the autoimmune hepatitis, and then towards celiac disease.
Yep.
So all of them I find out then higher anti-TDG.
Right.
But when I take the biopsy from the small bowel, they are totally normal, even no in the IDC at all. So
Yeah.
how would you comment on that?
Yeah, it's great. Yeah, it's this first we need to know how high the TTG-IgA. In Europe, they have a guideline if 10 times about upper limit of normal. So the higher chance those individuals have villus atrophy. The second, regarding how much pieces of biopsy you taken. In earlier studies, we particularly by Ben Lebois and that done in Colombia, they recommend to have at least 6 pieces on the second portion and at least 4 pieces from the duodenum bulb. And other part is related to the cutting, the pathologist, how the pathologist reading those slides. They have to put the piece on with good orientation. Otherwise, the villus couldn't be appropriately evaluated. So those are sort of situation we should consider. Um, yeah, those cases with really high TTG-IgA that have minimum pathologic findings. Should we treat them or should we not? I think we should.
So for those cases, like what Cindy was suggesting, you have a positive serology or you have a negative biopsy from the duodenum. In those cases, do you think the capsule small bowel capsule endoscopy plays any role to see the rest of the small bowel?
You ask, yeah, I think we should. There's, talking about the capsule study, there's different ways of analysis. Some of the small bags capsule can evaluate the villus structure more broadly. Especially there was a paper in gastroenterology about those imaging and AI to automatically identify the areas with villus atrophy. But it's I don't know how about you guys practice, how you do.
So you have not find it very helpful, huh? Sounds like.
Yeah, probably Dr. Chu can comment. Do you find the capsule be helpful or not really?
Well, I don't do capsule for celiac disease because it's very you're looking for villus and atrophy. That is
Yeah.
very extreme case. For
Yeah.
most of the case is only ICE, the positive.
Yeah.
So my second question is, I know the IgA deficiency is the increase in celiac disease. So then you test an anti-TTG IgG. But you still follow that or?
Yeah, that's a great question. I don't have the time to mention that yet. When patient have the selective IgA deficiency, we will rely on the deaminated gliadin peptide antibody. Unfortunately, the concordance between deaminated gliadin peptide antibody, both IgG or the TTG IgG, is not great. And so we don't have, as I mentioned about TTG IgA was not standardized, but even with other, we are not really know which criteria, what's the cutoff we should use. Yeah, but gluten challenge or gluten-free diet, in some case scenario, especially for those with selective IgA deficiency, would be considered. It could be helpful, and biopsy will be helpful.
There's one last question if we still have time. Do you see a lot of migraineurs in celiac patients?
Migraine.
Yeah,
Yes.
migraine.
Yes. So, especially for those young female college students, they can have both. They have migraine and celiac disease. They're young, but they feel so tired. They have no energy. That's frustrating.
Yeah, actually, I just saw a patient recently who does not have celiac disease, but she has been on gluten-free diet for 10 years. She says she has horrible migraine headaches, and her neurologist tried everything, and finally her neurologist says, you know what, just go ahead and try gluten-free diet. When she tried that, her migraine headache became completely manageable, and she has been voluntarily staying on gluten-free diet, and she never had actually established celiac disease.
Yeah, we as GI, we saw such patient. Yeah, I agree. And the non-celiac gluten intolerance is a true problem. The problem we don't have enough how to diagnose. There's currently a couple of sort of expert consensus republished. But how we diagnose them, how we identify them, and treat them properly requires a lot of more future studies.
Yeah, James. So for those kind of patient, I always run the HLA-DQ2 and the HLA-DQ8. If both negative, I don't say, hey, you don't have a celiac disease, so don't waste your
Exactly.
Yeah, that's an excellent point. I usually don't test them because for all practical purposes, they're going to stay on gluten-free diet anyway, so why bother?
Yeah.
Yeah, I think that's all the questions we have.
All right. Well, we had a lot of discussion. Thank you all.
Well, thank you so much for the wonderful talk.
Thank you so much. Yeah, wonderful.
Thank you.
Yeah. Bye.
Good night, everyone.
Good night, everyone. Thank you.
night.
It's very nice. Actually, the way I was asking is that, as a PCP, we will try if gluten-free diet can help, do it. That's why Dr. Ni was mentioned about.
It used to be such a onerous request
Because
for
some
someone to
people,
go
they
onto a
just
lifelong gluten-free diet.
Yeah.
And now many patients don't mind doing it because gluten-free diet has become cheaper and more readily available by mail order, many ingredients that can cook. But in the old days, when you go for gluten-free diet, oh my God, your food cost will triple, and it's very difficult.
Yeah, for those patients, I always discourage them. The reason for that, I say, do you know how much the gluten you you're not to be gluten-free. And I said is years ago, FDA actually gave a guideline is 1/8 of teaspoon flour. And then, or you can just say you cut a piece of bread, 100 pieces. And then because a piece of bread is like 2 grams of gluten.
Right.
So you only need 20 milligrams the gluten, and then you're not gluten free. So it's like 1 piece of 100, cut 100 piece of the pieces into a bread, and you just take 1 piece of that. And then they say, okay. So
It's very powerful. I remember we had a case of so-called refractory celiac disease many, many years ago. We took careful history. It turned out he was receiving a communion from his Catholic church priest. And that was the contamination. And once that was taken away, his refractory celiac disease was controlled. So history is very important.
Exactly. Exactly.
it's great.
All right.
Great.
Thank you.
Thanks, everyone.
Thank you.
Have a good night. Yeah.
Good night.
Very good discussion. Thank you.
Bye.
Sorry, I'm trying to answer the last question about email address. I'm not sure if that person saw my answer, but anyways, thank you so much.
Okay. Bye-bye. Good night.
Bye. Thank you.